Hello and welcome. In this video, we'll be discussing the structure of the thyroid gland and its relation to other structures of the neck. This clinically matters because it forms the basis for understanding the clinical approach to neck masses. You can see I've pre-drawn a median view of the neck, and I've written over on the right side the list of structures that we need to place on it because they all have clinical relevance. Start with the tongue. Note that the tongue is divided into an anterior 2/3 and a posterior 1/3. They have different embryologic origins and different innervations. You can recognize this clinically when you look at the tongue because they're divided by the circumvallate papillae. And sitting right where those join at the back of the tongue is the foramen cecum, an embryologic residue of the site of where the thyroid gland initially forms. The thyroid gland then follows a pre-established duct, the thyroglossal duct here, and uses it as the directional tool for migrating down to its position in the neck. And one can see immediately there's going to be two clinical associations with that. The first will be if the thyroid doesn't migrate, then that will leave us with a lingual thyroid. And when you look in the mouth, you see a cherry at the back of the tongue, and that represents the total sum of the body's thyroid gland. If we have a failure of involution of the thyroglossal duct, that can accumulate fluid and form a thyroglossal duct cyst, which is part of the differential of neck masses. The second thing to note when we look at the relationship of the tongue to the thyroid is that when the thyroglossal duct involutes, it leaves a fibrous connection, so that any time one swallows, that is defined by the back of the tongue rising to the palate. Anything that has been attached to the thyroglossal duct will rise with it. This is the basis of the swallow test. Anytime you have a neck mass and the patient swallows, if the mass moves upwards, then you know it has to be connected to the thyroglossal structures and will be thyroid in some sort of basis. Other structures of note include the epiglottis here. The epiglottis covers the trachea during swallowing to prevent aspiration. The epiglottis, however, has a predilection to be infected by Haemophilus influenza. This is not as significant nowadays because there's H-flu vaccination, but in your unvaccinated patients, epiglottitis can be a cause of asphyxia from an edematous epiglottis. It's important to take a look at the bones. There is the hyoid, thyroid, and cricoid bones, and each of these has a story to tell. The hyoid bone is important in forensic pathology because when one is murdered by strangulation, the compression of the neck invariably leads a fracture of the hyoid bone. So in any forensic autopsy, the first act of the pathologist is to carefully dissect out the hyoid bone to rule out a fracture. The thyroid cartilage and the cricoid cartilage are connected by the cricothyroid ligament. When one needs to do an emergency tracheostomy, this is a very safe place to do the puncture wound as long as it is midline, away from the major vessels. Other things to note, the middle of the thyroid, if one drew a thyroid gland, one would often find this right here, and that is a pyramidal lobe. So when you look at the middle of the thyroid there, the pyramidal lobe is often thought to be a residual structure from the last thyroid migrating down the thyroglossal duct. Neck masses then are a very common problem in clinical medicine. If one takes a look at age as the parameter, in a child, it is likely to be benign. In an adult over 40 years of age, malignancy is likely enough that your investigation must rule out malignancy as the intent of the investigation. When one looks at time frame, if the mass has been present less than 2 weeks, then it is most likely to be benign. In the differential diagnosis of neck masses, they break into thyroid and non-thyroid masses. And the basis of the differentiation of these two is going to be the swallow test. In the previous page, we noticed that the tongue is connected to the thyroid gland. The act of swallowing raises the back of the tongue up towards the palate. Anything connected along the residual structures of the thyroglossal duct will lift the structure up. If there is a thyroid mass or a thyroglossal duct cyst, then by placing one's fingers over the front of the neck, with the act of swallowing, one will feel these masses rise upward. So the swallow test is the first fundamental division of all neck masses into thyroid and non-thyroid. Once one's decided thyroid, non-thyroid, then the commonest causes of thyroid will be a multinodular goiter. It's going to be a lumpy, bumpy thyroid, and it's very common. A cyst will often be a single discrete mass, but its cystic nature can often be difficult to confirm by palpation, and so typically that's going to require ultrasound to show the internal fluid. And then after that, one talks about nodule, which by implication means solid. And so this will be the benign adenomas, and then what we're really worried about, which is the carcinomas. Non-thyroidal masses are overwhelmingly lymph nodes, and we'll talk about the rule of 80s later when we talk about lymphadenopathy. Other causes are the thyroglossal duct cyst, the branchial cleft cyst, and these are embryologic remnants, so they tend to be in the young adults. And then there are some very rare tumors, such as the paraganglioma. A goiter, by definition, is any thyroid mass, so it's really not a terribly useful term. Anytime you use the term goiter, you should always qualify it with an adjective. If it is a diffuse goiter, meaning the gland is uniformly enlarged without discrete abnormalities, that is going to be Graves' disease. If there are multiple nodules, then that's going to be a multinodular goiter. And in the American population, this is the commonest thing that we see. And if it's a discrete single mass, then that is called a nodule. Nodules are everyday working medical problems. If you examine all thyroid glands by palpation, in adults, you will find nodules in 4% of the population. But with the new adaptation of ultrasound, we're going to find up to 50% of thyroid glands are going to have nodules. Rules have been adopted that you do not investigate a nodule found by ultrasound unless it is greater than 1 centimeter and it is solid. Cancers are actually quite uncommon and constitute less than 1% of thyroid masses, depending on age and gender. Over 75% of them are going to be papillary cancers, and these have a very indolent behavior, so even the fact of finding a neoplasm in the thyroid nodules doesn't have clinical importance to your patient. When we talk about the testing, if it is functioning, meaning that it is producing thyroid hormone, then it is benign. Because functioning produces T4, then the first test that we start with is going to be a TSH. Because if the TSH is low, it's because it's being suppressed by the thyroid and functioning nodules are benign. The problem with using TSH as the first test is that it requires quite a large amount of tumor. In other words, we're not going to see TSH suppressed by thyroid until the tumors tend to be at least greater than 1 centimeter in size. Usually we're talking about tumors that are going to be at 2.5 centimeters. The next test that we do to determine functioning, non-functioning is to do a radioactive iodine uptake. And this is not hard iodine of nuclear weaponry. This is a much safer I-128 iodine that is injected into your patient and then preferentially collected and secreted by the thyroid gland. And there are 3 common patterns in hyperthyroidism. This is the normal appearance of radioactive iodine uptake. A, this is a diffuse uptake and the gland is enlarged. This is the pattern that we're going to see in uniform stimulation of the gland in Graves' disease. The second pattern, this very discrete area of markedly increased uptake. In addition, the rest of the gland is down. If we think about how thyroid works, hypothalamus, pituitary, thyroid gland, releasing hormone, stimulating hormone, and then suppression by the T4, we can see that this discrete nodule is increasing the T4, and by doing that, decreasing the TSH. So that's suppressing the rest of the gland. And this is the classic pattern that we're going to see in a functioning adenoma. These are benign, and you don't need to do further surgery. When we look at C, we can see that the whole gland is non-functioning. But remember, this is a hyper patient. And so there's two situations that can do this. One is if the patient is taking exogenous thyroid hormone, such as a child getting into the mother's synthroid. The other cause of this can be Hashimoto's thyroiditis. If the destruction of the gland is rapid enough, it can release preformed T4 that then suppresses TSH, and so we see a decreased uptake of the iodine by the gland. Radioactive iodine uptake is a useful test for the three commonest patterns that cause hyperthyroidism. Ultrasound is going to be the everyday routine test that you can do in your office. So it behooves us to have a quick look and understand what we're seeing when we look at it. Here's going to be our trachea, and here's going to be the strap muscles over the anterior neck. The thyroid gland itself is going to be here. And then we can see there are going to be two other structures that show up as fluid. This is going to be here, which is going to be our common carotid. And then the other vascular structure that we're going to see is going to be the internal jugular vein. Sometimes you can get it far enough back that you can actually see the esophagus here. So there's your basic gross anatomy of ultrasound. These are going to be two common patterns that we see then when you apply ultrasound to a mass. The commonest pattern we're going to see is this cyst. And the key in any cyst in any organ is to look along the wall, because if it's going to have malignancy, you're going to see growth off the wall. If you see none, this is a benign cyst, and as you can see, this is designated in ultrasound literature as having very low suspicion. You can stick a needle and aspirate it and collapse it, but you don't need to do further investigation. Compare that now to the cyst over here on the right, because the cyst, first of all, is going to be large. It's greater than a centimeter. The second is going to be there are internal contents, and those internal contents are most likely cells. Cells proliferating equals neoplasm, so in the ultrasound literature, this would be very high suspicion, and one would go on to fine needle aspirate and perhaps excisional biopsy. Thyroid neoplasms are common. By far and away the commonest, 75%, is going to be a papillary carcinoma. We don't need to know a lot about these. As you go further into clinical medicine, you can learn them in detail. But the thing to remember about papillary carcinoma is it is indolent, meaning it is very slow growing. In fact, pathologists have for years been trying to get the moniker carcinoma dropped and call it a papillary proliferation so that patients aren't as worried about the diagnosis. The second thing to remember is that it has a very characteristic finding on fine needle aspirate. It has these little calcific bodies of these ringed structures that are very helpful in proving that it's a papillary structure, and these are our Samoma bodies. Samoma bodies are also seen in serous carcinomas of the ovary where they're critical in diagnosis, and then just to complete the discussion, they're also seen in CNS meningiomas. The second commonest cancer is going to be a follicular carcinoma. Follicular carcinomas are highly variable in their behavior. It's very hard to reassure a patient on how it's going to behave. The one thing to note clinically is they actually may uptake I-131. So if it's an iodine uptake tumor, then you can use the gamma-emitting I-131 as a basis of treatment. And then the third cancer, which is the one we spend most of our time talking about, this is a medullary carcinoma. These are actually quite uncommon, but they matter because 30% of them will be associated with multiple endocrine neoplasia type 2. The second to note is that it doesn't arise from a thyroid cell, but it actually arises from the calcitonin-producing cell, which makes it a neuroendocrine carcinoma. The calcitonin cell, no surprise, produces calcitonin, which means that this is a very good serum marker of the tumor. No, it does not affect the body's calcium level. Calcitonin can beta-plete, which means it's going to form amyloid. In non-thyroid neck masses, by far and away the commonest cause is lymphadenopathy. Let's start by drawing ourselves a standard head and neck. The first set of nodes is going to be right here, and that's going to be submental. Submental lymph nodes are important because they're going to drain the anterior mouth. And when we talk about squamous cell carcinomas of the head and neck, the common ones associated with alcohol and smoking are found in the anterior mouth on the side of the tongue or the floor of the mouth. Here we find the submandibular lymph nodes, which are classically coming off the face and other internal structures of the head and neck. And then we come to the most important one here, which is going to be our tonsillar. This is the classic jugulo-digastric lymph node of strep throat fame, but in adults, the tonsillar lymph node is critical because it actually drains the oropharynx. And now we're going to pick up the other pattern of head and neck squamous cell carcinoma, which is related to the HPV infection. So that one can see that the cause of squamous cell carcinomas has different primary sites. Alcohol and smoking on the tongue in front of the mouth, but the HPV related over the tonsil, and so the metastasis appears in a different spot. If we draw in the sternocleidomastoid muscles, then we can see, as we come down, here's a bit of the latissimus dorsi, and then here is our clavicle. We can see this defines the posterior triangle. And the lymph nodes now are going to be deep to the muscle. The deep lymph nodes really are non-specific because they drain all the others above. The next set of group we want here are going to be our supraclavicular. These are the so-called Virchow lymph node. This is where we're going to get the draining of the thoracic duct. And so this is a common site for metastasis from the upper GI tract like stomach and pancreas. The only other lymph node you're going to see a lot in clinical practice is going to be back here, which is the occipital. And this is a surprisingly common lymph node because it drains the scalp. So when you get into spring and all the children get out and get bug bites, that's a common site for a lymphadenopathy secondary to it. But it'll be benign, of course, because it's in a child, and it will have been present for less than 2 weeks. Lymph nodes are identified by palpation. And there are 3 patterns of palpation that you should always be aware of and describe in your physical exam. The first is going to be a soft and tender lymph node. These are acute reactive, and they're soft and tender because there's neutrophils, and so it's a marker of acute inflammation, and they're swollen because of edema. The next pattern is rubbery, meaning it's solid like an India rubber ball with a little bit of give. And this is the classic description of a lymphoma. And then the last is called stony and hard. And this is the classic of a metastatic carcinoma, because these metastases tend to produce collagen, so-called desmoplasia, and so you're feeling the scarring of the collagen, giving it that hard palpation. When you find any of these nodes, the testing is going to be fundamentally based on fine needle aspirate. And this is very effective in diagnosing the squamous carcinomas and the wide range of morphology seen in reactive. When one talks about age, remember we're going to be talking about the rule of 80s, which says that when someone is over 50 years of age, 80% of neck masses will be lymph nodes. And of those lymph nodes, 80% will be malignant. And of those malignancies, 80% will be squamous cell carcinoma. And so you can see then, depending on which node you have, submental is going to be suggestive of the alcohol smoking, and the tonsillar oropharyngeal is classic for your HPV. Thyroglossal duct cyst is the duct that goes from the base of the tongue down to where the thyroid gland is. And if it does not completely involute, it can accumulate fluid, so that we're classically going to see these as a benign cyst, and it's got to be midline because it's arising in the previous thyroglossal duct. Therefore, because it's connected to the old duct, it will have a positive swallow test. If one does a fine needle aspirate, one will only get non-specific debris because there's no cells to pull out. And in a young person with a benign cyst and a negative FNA, you can just do a surgical excision to remove it. It's going to be midline down to the level of the thyroid. Now, branchial cleft cysts, as the name says, are part of the pharyngeal system. So if one takes a look at an embryo around week 5, we can see that there are the pharyngeal arches, 1 through 4. And if these don't completely involute, we can have a residual structure that can accumulate fluid. And these branchial cleft cysts, depending on which one that it is, tend to be either high up in the arch, if it's going to be in the first arch, or down lower in the sternocleidomastoid if it's a second. Again, when you do a fine needle aspirate, you're just going to get debris with no positive cells. They tend to be young adults, and you can simply do an excision to confirm. So that brings us to the end of this discussion of the thyroid structure and the clinical correlation that one uses in understanding the presentation of neck masses. Thank you for your attention. We'll see you next lecture.